Let's move on to proliferative diabetic retinopathy. So, what is proliferative diabetic retinopathy? This is actually the most dangerous at the apex of the diabetic eye disease, as you can see in the red color here. What happens? You have proliferative, you have abnormal new vessels which are on the disc, which may be NVEs, they tend to bleed and they threaten the vision. That is why you call it one of the most risky diabetic retinopathy, which needs urgent attention. When you do clinical examination, it is very important that you examine the patient before dilation to look for any iris neovascularization because this might be very important indicator and this means you have to do a very aggressive laser for this patient and watch out for the development of neovascular glaucoma. Clinical examination, you would look for neovascularization of the disc, RNVE, vitreous or preretinal hemorrhage, and fibrovascular proliferation. This is what typically you would see. There would be, these new vessels. You can see that as arborizing networks here and there, as indicated by arrows. And you have this cogwheel appearance of NVE here. And there would be some component of fibrosis because these new vessels grow along the posterior hyaloid. They use it as a support. So when they grow, the component is vascular as well as the fibrous component also comes in, and that's why you get this tractional kind of a component over a period of time. If you see angiography, it's more clear that because these new vessels leak and you can identify. Many times they may be quite subtle, and you may have to do a good clinical examination to look. But if you see a bleed, pre-retinal bleed, you must look because there have to be new vessels somewhere, and that will give you a reason to do PRP. Again, if you're not very sure, do a fluorescein angiogram, and these vessels will show you very nice areas of leakage. The first study which was done about proliferative diabetic retinopathy was long time ago between 1971 to 75, which is famously called diabetic retinopathy study. I will not go into too much details, but they just recommended that if you have high risk PDR, and what is high risk? If you have NVD, which is more than one-fourth to one-third disc area, any NVD associated with vitreous or preretinal hemorrhage, or NVE, which is more than half disc diameter, associated with vitreous hemorrhage and or preretinal bleed. If you have any of these characters, this needs immediate PRP. And if you do not do it, this is a very high risk of going blind or legal blindness. Now, the treatment option, pan-retinal photocoagulation, is the standard of the care. Anti-VEGF, in my practice, I do add, for example, if there is a florid NVD and there is also macular edema, I know that this NVD is going to bleed and may not even give me time for completing the PRP. So therefore, when you are starting PRP, you also give anti-VEGF along with it to take care of the new vessels. So it's very important when you see the patient with PDR, as I showed. First thing is you see whether the patient has high risk characteristics or not. And I already mentioned these three high risk characteristics. If they are present, then you do not wait, you straight away do PRP. And anti-VEGF you will add if there is florid neovascularization and if there is macular edema associated with it. The DRS study was followed by ETDRS, which was between 79 to 85, and they said the same thing. If you have high risk characteristics, immediate PRP. And if you will have to defer, that is only acceptable if they are non high risk characters of PDR. This is how a good PRP would be, that you have taken care of, and over a period of time, you can see the regression of all new vessels. Non high risk is something you're suspecting here, and you find this small new vessel. Now, this is PDR, but this is non high risk proliferative diabetic retinopathy, and this does not require immediate laser. You will look whether the patient can come back to you for compliance or not, and depending on lot many conditions, is there too many areas of capillary non-perfusion? You can do PRP in this patient, but it does not have to be like emergency PRP. You can do a good systemic control of macular edema and PRP. When you're doing PRP, just make sure that the spacing, the burns have to be one burn width apart with a spot size about 200. The total burns are about 2000 to 2500, but you don't do it all in one sitting. Because if you do too many burns, there will be macular edema, worsening of macular edema. So you divide it into 2 to 3 sittings, of every weekly sittings, and be careful not to come too close to the disc. The nasal limit should be about 500 micron away from the disc, and temporal 2 disc diameters from the foveal center. There are not many complications. I'm not going to narrate them, but the most common limitation is that your night vision goes away, peripheral visual field loss. There is worsening of macular edema, and for that reason, you may have to combine it with anti-VEGF. So, are there any solutions to it? Really not, because targeted retinal photocoagulation, some people do, but it has not found to be the standard of care yet. And combining with intravitreal anti-VEGF, mainly for macular edema. When will you give intravitreal anti-VEGF? If we look at the evidence, DRCR protocol S showed that treatment with ranibizumab resulted in visual acuity that was non-inferior to PRP at the end of 5 years. And the clarities demonstrated that aflibercept was superior to PRP in terms of visual outcomes at 52 weeks. And I would just like to bring to your attention that when we are talking about these protocols, we are talking of giving only anti-VEGF and not doing PRP because we want to save the field. Now, what is the advantage of treating only with the injections is you have a better visual acuity outcomes and you do not have the field loss. However, what is the problem? The problem is in settings like ours and yours. It requires very strict follow-up. It requires huge number of injections, which is economically not affordable to many of our patients. And there is also a risk of rapid progression if the patient does not come back to you for follow up. So, this is not at least we follow in our practice. We generally give 1 or 2 injections and support it with PRP. You have to be aware of the crunch if you are injecting, and especially if there is a component of fibrosis, because this is how the active new vascularization looks, and this is the fibrous tissue there in the background, which is leaking. Now, when you give injection, the new vessels regress, but the fibrous tissue starts shrinking. So you may have an increased risk of tractional retinal detachment. Therefore, when you are giving anti-VEGF as a supplement to your PRP, just make sure there is not too much of fibrosis, which can undergo a crunch phenomenon. So, the foundation of retinal salvage, which means is there any adjunct? Adjunct remains the same: glycemic control, proteinuria control, and look at the macular status, because don't keep on pushing PRP simply because the patient has PDR. If there is PDR with macular edema, you will have to give anti-VEGF to treat macular edema along with PRP. Many times these patients do come back. You have done a lot of PRP, but there are new vessels now which have come up. You may have to give anti-VEGF or do supplement laser to some of the skip areas which you might have left in the previous sitting. So this is the unified care of PDR pathway, which is systemic control, high risk trigger identification. First line is complete PRP, and if there is non-clearing vitreous hemorrhage, or if you feel PRP cannot be completed for any reasons, there is dense cataract and there is vitreous coming on the way, then surgery. And if there is refractory or there is macular edema is present, you will have to combine anti-VEGF along with this. So the seamless continuum of care is metabolic control, anatomic stabilization using PRP, and surgical salvage if your PRP does not work or if the disease goes into tractional retinal detachment. With this, I would like to thank you all again, and we will now move on to cataract surgery.